Hello everyone, thank you for attending my presentation about MR-guided focused ultrasound treatment for osteoid patients. In our research, our purpose was to determine the feasibility and the clinical efficacy of the MR-guided focused ultrasound treatment for osteoid patients. And what we were trying to aim is the pain relief in these patients, because in fact, in osteoid one of the main clinical factors is the fact that there is very high intensity pain in those patients. In our research, it was a prospective study. We involved 29 patients, and in fact, one of the most important parts in choosing those patients is that the lesion will be acoustically accessible. And we could not have any patient with a vertebral body osteoid due to the fact that when you have vertebral body osteoid, it's harder to address it and it's much more complicated and dangerous. We used the 3T MR unit coupled with MRgFUS therapy. And we had two endpoints. We had the primary endpoints, which was the adverse event, and the pain relief, which was assessed by the VAS score and by the intake of NSAIDs, the daily intake of NSAIDs. And when we were talking about the secondary endpoint, we were referring to the CT and the MR with 6 to 12 months and 1, 3, 12, and 24 months respectively. And this imaging can evaluate the inflammatory response in the edema. And this is very important because one of the, again, main factors in osteoid is the fact that you have an inflammatory response that causes this increased pain that we are talking about all this time. This is a great example of how does it work. So we have a lateral aspect of the knee. And you can see with the arrow the lesion itself with the inflammatory response and the edema around it. And then when we're looking at the MR-Thermometry, you can see surrounded by this circle, the thermometer can measure the temperature, which is of the energy deposition. So in fact, these represent the heat, the temperature that increase while we're pointing it on the nidus itself. So this is how it works practically. Our results were as we were expecting them to be. We had a complete clinical response in 93% of the patients. There were no adverse events in the treatment itself or after the treatment. And regarding imaging, as we said before, checking with CT and MR, we saw that there was no edema or no inflammatory response even a day after the treatment. This is quite an interesting case because we're talking about a case that is one of our first cases. This is a 16-year-old girl, and as you can see right over there, we can see the sclerotic lesion and we can see nidus. And in fact, she has another nidus right over here, which was actually caused due to the fact that she had a prior radiofrequency ablation, and due to the drilling, it causes the formation of another nidus. And we tried to treat it it was one of the first patients, we tried to treat it in a different way, and in fact what we did was to try to treat it with treating the periosteum denervation. And it didn't work. She eventually went through a surgery, but we learned from that the only way to treat the osteoid is directly ablate the nidus itself. This is another interesting case. What we can see here is a volleyball player with osteoma on the third finger and the metacarpal part. And we can see where the circle is, that it is the lesion itself, and also we can see the whole edematized part and the inflammatory response. And this is pre-treatment. And one of the main things that we need to look at is the VAS score 8, which means very, very intense pain. When we're looking on these 3 months after the treatment, we can see that the lesion is still there, but the edema and the inflammatory response is completely absent. And the VAS was, of course, 0. And if we're looking 24 months after, we can see that even the lesion is absent, so it is working. This is a perfusion study. What we can see here is that another main characteristic of the osteoid osteoma, and that is the nidus is highly vascularized. Therefore, you can see the high perfusion in that area. And in fact, in the time, as we saw before, the 24 months, the VAS is 0, and in fact, you don't see any perfusion of that area, which is causing the inflammatory response and the edema that causes the pain. Our last case is a case of, again, it's a femur. We can see where the errors are, that we have the increase of the inflammatory response and the edema, and in fact, after 6 months, as you can see, there's no inflammation in that area. Our conclusion is that this treatment works. It's fast, it's non-invasive, it's not dangerous. So it's very, very good for especially kids that doesn't have to go through surgery. And with more time that we work with people and we get more patients, we learn from our mistakes, we accumulate knowledge, and eventually we will get better results for our future patients. Thank you for your attention.
We have time for one quick question.
I noticed from one of your slides that you put the focus deeper than the periosteum. Is that because you then get more heating at the periosteum, or do you think you're getting quite a lot of energy right into the bone?
Well, good question.
Well, may I try to respond? Both, probably, because the position of the energy into the bone probably is also related to the amount of energy that you touch with the surface of the bone. I'll probably give you an example in my following presentation.
Okay. Thank you.